Good morning, everyone. We are so appreciative that y'all are here. Before we get started, I wanted to share a few quick things from our continuing education partner. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through the joint providership of the Medical Education Council of Pensacola and the Mercer University School of Medicine. MECOP is accredited by the ACCME to provide continuing medical education for physicians. MECOP designates this live activity for a maximum of 5.5 AMA PRA Category 1 credits. In accordance with the policies of the ACCME, MECOP has collected disclosures from the speakers, planners, and reviewers involved in this activity. None of the speakers, planners, or reviewers have any relevant relationships with ineligible companies to disclose. Thank you.
Hi, everybody. If you've been to any of our conferences before, you know I usually kind of come up here and wing it, but that doesn't always work out so well. So I apologize if I'm reading a little bit, but I want to make sure and get in all the goodies of today. But I'm Glenda Grant. I'm the Executive Director here at the Georgia Rural Health Innovation Center. We are so glad that you are here. This is a part of our ongoing programming for Kids ABC, which is an alliance between Children's Healthcare of Atlanta, Mercer University School of Medicine, and its Georgia Rural Health Innovation Center. So we are thrilled and tickled that you're here today. We noticed that there are a lot of empty spaces, so people may be coming in and out. We're not exactly sure what's happened. We're thinking maybe there's been some traffic-related issues and people getting in, but we're so glad you are here. We're thankful and we're grateful for you, and we're going to have a great day. Whether it's 1 or 100, we know that you're going to hear great information today. And we have assembled some really spectacular speakers for this roster and for this agenda today. So we're super excited. But we're so pleased that you're here as community leaders, nurses, doctors, healthcare professionals, school professionals, because we know that we need to talk about the most important heart of our community, and that's our kids. They're our future, and particularly in rural spaces, the care that you receive, the things that you get shouldn't be dictated by the zip code that you live in. And so for us, for the Rural Innovation Center, we're of a particular interest in getting these resources to rural communities. So if you've traveled far to be here, we're grateful. You may be from an urban space and have traveled far to get here. And so we're grateful for that too. We appreciate you so much. We're going to have a great day, and it's going to inform and empower you. We're going to talk about a lot of practical things, tools, and new ideas. I hope that you'll take the time to get to know the people around you at different tables, because they're going to have insights and things that you may not have, and you're going to have insights that they may not have. And I think that's also a powerful tool, not just the people who stand behind the podium, but also you, because you're an expert in what you do. And so make sure and talk to the people around you, get to know them, exchange numbers. Something that you're doing may be just the answer to your neighbor's table of something that they need in their community. So make sure and get to know one another. But before we dive into all of our things, I want to introduce Michael Dykes. Wave your hand, Michael. He is our new Director of Rural Pediatric Programs and Projects. And so you're going to see him. He's going to be in your community, traveling there. He comes with a wealth of knowledge and information from his many years in healthcare, and he's a nurse, amongst many other things. But he brings that fantastic clinical piece to everything that we do in the Innovation Center now. And his passion for children's health care and for bringing innovative solutions and ideas to communities is really going to make a big difference in our programming. We're so grateful that he's here with us. So without further ado, we're going to go ahead and get started with our day. Thank you.
All right. Well, again, my name is Michael Dykes, and it's an honor and privilege to be here. This is day 5 for me, my first week. So I was invited, voluntold to speak. So so we're going to introduce our We're going to introduce our first speaker. It's Dr. Neha Desai, and I'm going to read a little bit about her background. Dr. Desai is a pediatric hematologist and oncologist at the Aflac Cancer and Blood Disorders Center of Children's Healthcare of Atlanta. She also serves as the assistant professor of pediatrics at Emory University School of Medicine. Dr. Desai has earned her Doctor of Osteopathic Medicine degree from Lincoln Memorial University, DeBue College of Osteopathic Medicine, prior to receiving her residency training at the University of South Carolina in Columbia, South Carolina. After her residency, she completed her fellowship training at Case Western Reserve University School of Medicine and University Hospitals, Rainbow Babies, and Children's Hospital in Cleveland, Ohio. Dr. Desai's clinical interests include benign hematology with an emphasis on sickle cell disease. Her research interest focuses on sickle cell disease and utilizing clinical databases. So welcome, Dr. Desai.
All right. Can y'all hear me? Okay. Good morning, everyone. Thank you for that lovely introduction, and thank you all for inviting me here. I'm really excited to give you guys a brief talk on pediatric sickle cell disease. So as you said, I'm Neha Desai. I'm an assistant professor of pediatrics and one of the hematologists within Aflac Cancer and Blood Disorder Center. And again, I am a primary hematologist with a specific emphasis within sickle cell disease. So today we will talk about pediatric sickle cell disease. I have three main objectives that I want to go through. So first, we'll review newborn screening and specifically hemoglobinopathy screening. Second, I will give just a general overview of sickle cell disease. And then third, we'll go through quite a few different acute complications that I think are important, especially in a rural setting that you may encounter. And so you can know what to do with diagnosis, treatment, when to refer, when to call, etc. So first, we will go through the hemoglobinopathy screening. But before we get there, I want to talk a little bit about hemoglobin. So this picture illustrates the timing of the switch from fetal hemoglobin to adult hemoglobin. So fetal hemoglobin is alpha and gamma globin chains. Adult hemoglobin is alpha beta. So hemoglobin F, fetal hemoglobin, hemoglobin A, adult hemoglobin. And then that switch occurs around 6 months of age. So as you can see on this image, they depicted around 9 months of age is really when that intersection happens. So after that time period, babies will produce more hemoglobin A or adult hemoglobin than they will fetal, which is very important when we're talking about sickle cell disease. And then as you can see at the bottom within that red box, the beta globin chain is on chromosome 11, as is gamma and delta, which is also very important. So this image goes through the genetic basis for sickle cell disease, in which you're going to have either very little or no hemoglobin A, so that adult hemoglobin. So as I said, it's on chromosome 11. Now, if the normal glutamic acid is replaced by valine at that 6th position, you are going to make sickle hemoglobin instead of that normal beta hemoglobin. That is where sickle cell disease comes from. There's another specific genotype called hemoglobin SC disease that's also sickle cell. So if that glutamic acid is replaced by lysine, that will lead to hemoglobin SC disease. So now we know the hemoglobin switch. We know a little bit about the genetic basis. So why is this so important? How does this translate to newborn screening? Before we get there, though, I did want to show a little picture which I thought would be helpful. Hemoglobin A, adult hemoglobin, made up of 2 alpha and 2 beta globin chains. Then as you can see on the right, hemoglobin S or sickle, again, still made up of your 2 alpha, but instead of that normal beta globin, you're going to have sickle. This is what will polymerize under hypoxic conditions and have that sickle shape. So the way I explain it to parents and patients, because most people don't know what sickle shape is, I'll tell them it's a crescent moon, a half moon. I've had a younger patient of mine describe it as a half donut shape. So that's how I tend to describe it now. So in whatever way that you can explain it to your patients. So now, newborn screening. Under Georgia legislation, universal screening for sickle cell was mandated in 1998, and this actually did not become mandatory in all states till 2006. Now, out of everything you get from this lecture, I think the most important thing I want you to understand is that it is very important how the result is listed on the newborn screen. It goes from order of highest amount of hemoglobin to the lowest amount of hemoglobin. So a normal result, what baby should be born with, is fetal adult, so FA, because they will have the highest amount of fetal hemoglobin and then a very small amount of adult hemoglobin. So fetal A, or FA, normal. As you can see on this one, so the first one is fetal sickle. So that means, again, you have the highest amount of hemoglobin F, as you should, but your second highest amount is hemoglobin S, or sickle. So that means as your fetal hemoglobin production decreases, sickle hemoglobin will become the predominant one. And there is no adult hemoglobin in this. So this will indicate two specific types of sickle cell disease genotypes, which we won't be able to actually diagnose till closer to a year of age, but either genotype SS, so hemoglobin SS disease, or something called S beta thalassemia 0. For how I educate my parents, the clinical phenotype of the two is the same. So for both, we do the same sort of management. It's just important to know in terms of family planning and just genetics in general. In sickle beta thalassemia 0, you have loss of a beta globin chain on one of those, so you're not making a normal adult hemoglobin at all. So you're not going to have any of those. So you're going to have a little bit of that excess alpha globin that has to pair with something. So either pairs with sickle or it can pair with delta, which is hemoglobin A2 alpha delta, which is why you'll see in that column with hemoglobin A2, you're going to have a higher percentage in that sickle beta thalassemia 0. Now, I did put in parentheses SHPFH, that's sickle hereditary persistence of fetal hemoglobin. This is not actually sickle cell disease. So if this is a deletional change, you're going to have pancellular increased amounts of hemoglobin F in all your cells, and it overpowers that sickle. So you're not going to have the clinical phenotype of sickle cell disease. So in the best case scenario, a child would have sickle HPFH. This is something that we cannot diagnose till they're after a year of age because babies are born with the highest amount of fetal. So we really have to trend and see what their fetal hemoglobin is at a year of age, unless you're to do genetic testing beforehand. The next one is FSA. So as you can see in this one, there is a little bit of adult hemoglobin production. It is less than sickle. So this will indicate sickle beta thalassemia plus because you are going to have a little bit of that beta globin chain production. So you are going to have a little bit of A. The clinical phenotype of this one will vary based on the amount of hemoglobin A that you have. FSC simply indicates hemoglobin SC disease genotype. Again, there is no A production in this one. And then FAS, you have more adult hemoglobin production than sickle, so this is sickle cell trait. Now, there is no test out there that is infallible, so sometimes we will see some inaccuracies. Usually what happens is a child that has a newborn screen of FS, we will eventually diagnose with sickle beta thalassemia plus, and that's because there was such little hemoglobin A production at birth that it wasn't captured on the newborn screening, so it's something that we'll catch at the confirmatory testing. So this is why getting them in to see a hematologist, ideally by 2 months of age, even 3 months of age is the most ideal because we need to do that confirmatory testing to confirm the results of the newborn screen, which in most cases are accurate, but you still want to confirm. So this is why prompt referral to our clinic is important. And we do prioritize these babies and we'll get them into our clinic. Now say, there have been instances in which families are shocked by the results. They don't believe it, which is all appropriate. They can't get into our clinic for whatever reason. Then I would ask that whoever is their primary care provider do get the hemoglobin electrophoresis, the confirmatory testing. We can still interpret it and start penicillin prophylaxis, etc. So it really is a team effort here. Now, the ones in the boxes are the major genotypes of sickle cell disease. There are others, SE, SO Arab, those that I won't go into, but these are the 4 main genotypes. So next, I'll just do a brief overview of sickle cell in general. So it's a group of autosomal recessive disorders. It was actually first published, a case report in 1910 by James Herrick, and then decades later, Linus Pauling actually established it as a disorder in 1949. So if you think about it, that's less than 100 years of age. And of course, we talked about the homozygous and then the compound types. So it affects more than 100,000 people in the country and then 8 million people worldwide. And that number is probably underestimated because there's a lot of children that we do not know about. It's 1 in 365 African-American births and 1 in about 16,000 Hispanic-American births. The most important thing from this side is the prevalence that are born with sickle cell trait, 1 in 13. And that's important because genetic counseling is so important, and that's often done by the primary care providers, right? We don't see many of these patients with sickle cell trait unless families want to be referred to us, which we're happy to see. But a lot of this genetic counseling, and I'll show some sheets at the end, is done by the primary care provider. So a lot of times we will see families, we'll see patients where parents were not aware they had sickle cell trait. They did not know that they could have a child with sickle cell disease. So it's quite a shock to go over. This figure shows, I really do like this figure because it shows all the different kinds of treatment. So there was something called the National Sickle Cell Act of 1972, and that actually authorized the establishment of federal programs. So for sickle cell disease education, research, treatment, counseling, etc. And then as you can see from this, as we had advances in the field, the life expectancy started to increase, but it's still much less than the normal population. And most recently, I think it's plateaued at about just over 50 years of age. So if you think about it, that's still significantly less than others. So we have preventative penicillin to decrease the rates of invasive pneumococcal infection, hydroxycarbamide or hydroxyurea, which increases hemoglobin F, and then screening and treatment for stroke prevention. I'm sorry. All right, so before we kind of go into the acute complications, I did just want to go over the pathophysiology. This is actually one of my favorite illustrations that I use in all of my talks because I feel like it just gives a very nice overview. So what you have is the polymerization of your sickle red blood cells. That is the hallmark. If you know that, you'll understand why everything else happens. These cells will polymerize or become that sickle shape in a hypoxic environment. They're very rigid, they're very non-deformable, they do not like to move through the blood vessels at all. So if you look to your left in circle C, you'll see endothelial dysfunction. These cells do not live as long as normal red blood cells and they break apart easier. They hemolyze. So you're going to have a lot of free molecules out there that also affect the endothelial cells. So you're going to have a lot of dysfunction there. On the right side, you'll see vasoocclusion. That's because, again, these cells are not flexible, so they get stuck very easily within the blood vessels. So you have impaired rheology, which is just blood flow, but the cells not only get stuck to each other, but white blood cells, platelets, everything. So it's just a constant state of inflammation, of stasis. You're going to have ischemia, reperfusion, injury. And unfortunately, this is a feedback loop where you're going to have repeated tissue and organ damage. So I tell families, it's not just the external manifestations that I'm worried about. It's more so the internal ones that you don't see until it's too late. Okay, now the majority of the time I do want to actually just spend on the acute complications because I feel like that's what you all will really see more than anything. This figure, I'm going to spend a little bit of time on this figure. It goes through the acute and chronic complications, acute in the yellow, chronic in the blue. And as you can see, it affects every single organ system in the body. And over time, it'll lead to chronic changes. Now, by the end of this, I'll sound like a broken record because I cannot stress to you the importance of sickle cell visits with us. But just as important are the well child visits that primary care providers do. It really is a team effort because we don't often, we see these patients every 3 months or a little bit longer, but they miss our visits. They may call the pediatrician. This is why just normal general health maintenance is so important. Your labs, your vaccinations, vision exams, dental exams, etc. Okay, so I'm just going to start from the top. So you have neurocognitive dysfunction. So many patients, whether they have a stroke or a silent cerebral infarct or not, they'll have some degree of neurocognitive dysfunction. So that includes lower overall attention, memory issues, executive functioning issues. They have lower academic functioning and poor social skills. So for a lot of our patients, that we have some of these concerns, we'll actually try to get neuropsychological testing. And then a lot of our kiddos have an IEP or a 504 plan in school. But that only works well if the school understands what is sickle cell disease, why it's so important that patients have accommodation. So this is where, our school teachers, social work, primary care providers, everyone is so important. Stroke, I'll touch on a little bit later. Sickle hepatopathy is liver disease. We do see that, unfortunately, and you can have something called a hepatic sequestration crisis, somewhat similar to a splenic sequestration crisis, but it can lead to liver disease. Gallstones, of course, you'll have in any disorder with hemolysis and any hemolytic anemia. So a lot of our kids do end up needing a cholecystectomy as well. Kidney issues, very big. We monitor this with annual urine microalbumin testing. And if they meet certain criteria, we'll start lisinopril to help preserve that kidney function and get them over to nephrology. Big thing recently, and there's been a lot of different talks and research into this, most recently we had a lot of talks about this at the American Society of Peds Hemonc conference, is delayed puberty and growth, and especially so the impaired fertility that's due to sickle cell in general, some relation to the hydroxyurea, and more so the preparative regimens that we use for bone marrow transplant and gene therapy as well. So this is becoming something that we ourselves are trying to do better about and talking with our patients. The other thing is impaired growth. The way I describe it to parents and the little ones is that your body has to focus on either growing or making new red blood cells. And you need to make new red blood cells to live, so the growth and development is a bit sacrificed. So a lot of these kids are smaller. And it may be that they were born small and they stay small, or they're falling off. So getting GI, our nutritionists, pediatricians, nutritional supplements, all of that is so very important. Priapism, something that every provider, sickle cell or not, needs to talk about with a young boy, starting at a young school age, needs to talk about so parents and kids are aware of this. Priapism is a prolonged erection. A lot of boys are embarrassed to tell their families, which is understandable, but there's a high risk of infertility, which sadly I've seen if it lasts for too long. So this is something that needs prompt medical care. You have avascular necrosis, so this sadly affects about 10% of patients, and it's due to the repeated sickling in a certain part of the bone. And so eventually you're going to have very limited or no blood flow to that area of the bone. So this is a very common cause of chronic pain. So you want to think about it if a patient comes to you and says, I keep having pain in my shoulder, I keep having pain in my shoulder, or it's persistent. They may still be functional and able to do what they need to do, but they have persistent pain. So this is something where they're going to need an MRI. We get ortho involved. Sadly, a lot of our kids do need core decompression or joint replacement at a very young age. Skin ulcers, more commonly seen in adults, though I do have it in one of my patients. Pregnancy, I'll skip over. Our adult colleagues that, thankfully manage patients that are pregnant. Functional asplenia, splenic sequestration, and acute chest I'll go into a little bit later. And then lastly, retinopathy. So this is caused by retinal vessel occlusion. So this can lead to significant visual impairment and even retinal detachment. So these patients are followed very closely by ophthalmology. Now, most of these manifestations are seen in the more what we call severe genotypes of sickle cell disease. So that's SS, S beta thalassemia 0. I like to tell families SC is on a spectrum. You could have a milder SC disease, or you could have a very severe clinical phenotype of SC. S beta thalassemia plus tends to be typically a bit milder, but again, we have some that are more severe. Retinopathy, and just that one specifically, is actually more commonly seen in patients with hemoglobin SC disease. So this is why getting annual and must be dilated, because you want to dilate the eyes to see the vessels. They need to get dilated retinal exams. I say starting around age 8 to 10 are what the national recommendations are, but they really need to get that yearly. And sadly, it doesn't often happen. So again, this is where having our primary care providers involved and then a team effort is such an important thing for these patients. So now I'll kind of go into a few of these complications in a bit more detail. The first is vaso-occlusive episode. This is the hallmark complication. It is the most common complication that you'll see that they'll have at home, that they'll present to the urgent care or the emergency department for. So basically what happens is you're going to have microinfarcts or damage in the tissue that's supplied by a specific blood vessel where you're having that constant occlusion. You're going to have some like increase in inflammatory mediators, which will lead to an electrical impulse. That is what leads to pain. So the most important thing that anyone needs to do when they're seeing these kiddos in clinic is talk about vaso-occlusive episodes. How often are you having them? How often are you treating them at home? What works? What doesn't work? What are your sites of pain? You need to know what are their typical sites of pain. And you want to start talking about this early. So I start talking about this by about their first or second visit that they have with us, because it can start as early as 6 months of age, which is why that first graph that I showed you with that hemoglobin switch around 6 months of age, when your fetal hemoglobin is starting to come down, remember, fetal hemoglobin is protective. It doesn't sickle. So as it's starting to go down and your hemoglobin S or that sickle is starting to go up, you can start to see complications. Does not mean you will, but you can. The one that we see in infancy is something called dactylitis. So it's basically a vaso-occlusive episode in the fingers and the toes. And the way I tell families is it doesn't have to be all your fingers on one hand or all your toes. It could be any sort of combination. Usually they're a little swollen. They may or may not be red and warm, but they're typically puffy. And these babies won't want to grasp things. They won't want to put their feet down. And so we do talk about pain management with families. It can be managed at home, but there are some that do need to come into the hospital for IV fluids and then other pain management, whether that includes opioids or not. So I kind of alluded to this, but you want to know the history. What are the triggers for pain crises for these kiddos? Dehydration is the most common one. Stress, inflammation, or any sort of infection is another one. Weather, cold weather, and not just specifically cold weather in general, but the acute change in temperature. So if kids were outside playing in 80, 90 degree weather, they come inside and the AC is blasting, that in and of itself can trigger a pain crisis. And the most important thing that I think a lot of people forget, including us, is girls that are menstruating, everyone mostly gets menstrual cramps, but that in and of itself can actually trigger a full-blown pain crisis as well. It may not be every month, but you'll see a pattern. It's every month or every other month they're coming into the hospital because they're having a pain crisis right around the time of their menses. And that's important to know because we can recommend some hormonal control to regulate their menses and decrease these admissions and pain crises. Home management. Let me go back. So sites of pain. So we have the most common sites, which include long bones, abdomen, chest. You do want to know what are typical sites of pain because, again, these are normal children, right? They're going to have issues that are not sickle cell related. So if someone comes in with belly pain, you cannot assume that every time it's just sickle related. They may have appendicitis or something else going on. So that's why it's important to know, okay, what are your typical sites of pain? And then pain plan just alludes to some patients may have their own individualized pain plan, so you want to know what works for them, what doesn't work for them. Home management, there are quite a few patients that can manage their pain at home. They don't call us, or they may present to the emergency room and then they're able to go home. So you have non-opioids. So Tylenol, ibuprofen, we'll prescribe muscle relaxers, warm baths, warm massages. You do not want to do anything cold. So none of that icy hot, no cold packs, none of those. Cold, remember, can trigger a pain crisis. And then, of course, we have our opioids. So either something like a hydrocodone or an oxycodone are two most common. When to seek care. So if a patient calls you, what I say is if you are having pain and you're doing around the clock meds for 24 hours and it's not working, you need to come in. Or if you're doing your things and it's been 2-3 days and your pain is still not better, you need to come in. And the main reason for that is after a few days of a pain crisis, your risk for acute chest syndrome significantly increases, and that's the most common sequelae that we see of vaso-occlusive episode. So evaluation in the emergency department or urgent care includes labs, so your CBC, your retic, and your electrolytes, plus or minus imaging. In our little ones, we tend to get a chest x-ray because they cannot tell us if they have chest pain or not, and we want to make sure there's no acute chest. And our older kids, they can tell us, so we will get it based off their symptoms. You do not wait for labs before administering pain medications. So at our facility, we do intranasal fentanyl, they'll get Toradol, and then whatever opioid that they usually get, unless they have their own individualized pain plan. And then the inpatient management is similar to the home management, except for they'll get IV opioids, whether that's intermittent dosing, so every 3-4 hour dosing, or a PCA. Some of our kids may have just such prolonged, persistent refractory pain that we get our pain team involved for ketamine infusions or lidocaine infusions. It's not as common, but it is something that we do. Non-pharmacological, this is where distraction is very important. Child life, physical therapy, pet therapy, art therapy, all of those things, and then making sure they have a routine. They're getting up in the morning, they're taking a shower every day, they're changing their clothes. And a lot of our patients don't do that. They'll be in the same clothes for 5 days and they haven't gotten out of bed at all. And it's just not good for their psyche. So we want to make sure that they have a routine. Respiratory hygiene is the most important, and that's to prevent the development of acute chest. So that includes ICS, which is incentive spirometry. At our institution, we do scheduled albuterol for any patient that's coming in with vaso-occlusive episode with PEP, so positive expiratory pressure to keep those alveoli open. Every institution does it a little bit differently. Where I trained, we only did scheduled albuterol for those that had a diagnosis of asthma or that we knew it worked. But you want some sort of positive expiratory pressure, whether that's through albuterol with PEP or with ICS, and you want to get them up and walking. That is the most important thing. What I tell patients is if they're not at that point where they can get up and walk, sit up in the bed, sit up in the chair. They cannot be laying all day. And then IV fluids, you want to be careful of your IV fluids. So I tend not to go past 1 times, which is what I think most people do. So 1 times the maintenance rate. So I'll do that for about the first 24 hours or so. And then as soon as I can, I will go down to 3/4 maintenance. You don't want to do any sort of overhydration, which can lead to pulmonary congestion, which can lead to acute chest in the lungs. So I'm very mindful of IV fluids. Now, if they're significantly dehydrated, more fluids are indicated, do what you need to do for the patient. Just be mindful of when you can start to go down. A blood transfusion in and of itself is not indicated for a pain episode. However, if they have other indications, severe anemia, acute chest, splenic sequestration, etc., do transfuse, but it's not an indication for pain in and of itself. And again, you want to think about other things. If the pain is persistent, it's in one area, nothing is helping, that area is swollen, it's warm, they have fever, you need to start thinking of other things. Is it a septic arthritis? Is it osteomyelitis? Do we need to do blood cultures and inflammatory markers, MRI, get ortho involved, all of those things. So again, you have to think of the other things. Could it be avascular necrosis? And the big one is something called DHTR, which is a delayed hemolytic transfusion reaction. Those kids will have very significant low back pain. And that is pain out of proportion in the sense that you are throwing all the medications at them and not a single thing is working. That should make you think DHDR. And then once they are going home, discharge criteria and home plan, I think the most important thing is for kids that have not had a lot of pain crises is you need to tell them what's realistic goal, right? Getting them to a 0 out of 10 in the hospital is not very realistic. It can happen, but it's not what usually happens. You're getting them to a point where they are functional and they can do their home medications at home and continue. So the most important thing is making sure they're available to get the medications, that they have the funds to buy the medications, and that they don't just stop these medications once they go home. They will have rebound pain and they will come back in the hospital. So you want to make sure that they're doing pain medications. I usually tell them ibuprofen for at least 48 hours and then opioids scheduled for the first day or so, and then they can go to as needed. But at least ibuprofen 1 more day than the opioid. Next, we'll go to fever. So every patient with sickle cell has an increased risk of infections due to functional asplenia. The spleen is important because it clears out your encapsulated organisms, so primarily your strep pneumo, but there's also Haemophilus influenza and Neisseria or meningitis. You have repeated infarcts of the spleen, leads to functional asplenia and immunocompromisation. The PROP study, which is prophylaxis with oral penicillin in children with sickle cell, looked at kids with SS disease in the 80s. It was between 3 to 36 months of age, and they actually very much showed that penicillin prophylaxis decreased invasive pneumococcal disease. And the trial was actually stopped 8 months early because there was an 84% reduction in these invasive diseases. Now, prior to prophylaxis, infection risk in kids less than 5 years of age was about 3.2 to 6.9 events per 100 patient years. With prophylaxis, that number went down to 1.5. So you can see why starting prophylaxis by 3 months of age is so important. Whether that's done by the pediatrician or whether that's done by us, it does not matter. PROPS 2 showed that we could stop prophylaxis after or once they hit their 5th birthday because the rates of infection were less after 5 years of age. A, due to vaccinations, and B, we think they just have a better immunological response after 5 years of age. Now, there are cases in which we have to keep that prophylaxis if they've had their spleen out, they're not vaccinated, or if they've had bacteremia with any of those organisms, we too tend to keep the prophylaxis. So this is why vaccinations are so important. So Menveo, and then now we use PCV20. So even though the rates of infection have decreased, it is still a medical emergency. There are breakthrough infections. Is it a strain that's not covered by the vaccination? Are they not vaccinated? Is there something else going on? So fever is 38.3 Celsius or higher, or 101 and higher. So when you are taking their history, have they had previous bacteremia? What's their vaccination status? And splenectomy. Those are the 3 things that you need to know for every child that comes in with fever. It'll dictate, are we going to just automatically admit them to the hospital? It'll dictate what antibiotic you choose. So of course you want to do labs and imaging, same as we do for vaso-occlusive, and you want to get those empiric antibiotics within an hour. Some institutions do ceftriaxone, which is what I did where we train. Our institution at CHOA, we do ampicillin. There were some cases, unfortunately some fatalities with ceftriaxone-induced hemolysis, so they moved over to ampicillin, which actually works very well. So whatever your institution does, but you need to get that empiric antibiotic within the hour. So every patient that has a fever, our team would like to get called because we need to know, because we'll be able to tell you, have they had bacteremia, do they have their spleen, etc. Now, if a patient calls the pediatrician and says, hey, my kiddo has a fever, you need to send them straight to the emergency department. It most likely is just a virus. It could just be otitis media, but they still need the full evaluation. Even if they've had vaccines, they got it the day before, and now they have a fever, and we think it's most likely a vaccination, they still have to go to the hospital. Some kids can be discharged right from the ER. They will get 2 doses of amoxicillin to cover while that blood culture is still cooking for the first 24 hours, and some need to get admitted for various reasons. The next one I want to go over is acute chest syndrome. So this is the second most common reason for hospitalizations and unfortunately the most common cause of death. There's a 25% mortality with this. And again, it's the most common sequelae of VOE, which is why I'm harping on about IV fluids and respiratory hygiene. The definition is you have to have an infiltrate on chest x-ray plus fever or respiratory symptoms, chest pain, cough, hypoxia. You do not have to have fever. There are times where we will make a clinical diagnosis of acute chest, even if there's no infiltrate on the chest x-ray. When I say infiltrate, I'm talking about there needs to be an opacity, not just a little bit of atelectasis or viral changes, but a true opacity. And the etiology is multifactorial. Is it something infectious like a virus or bacteria like strep pneumo? Is it inflammation, hypoventilation? The only way we'd ever truly know is if we did a bronchoscopy, which of course we're not doing in our patients. So you are treating with antibiotics in case there is an infectious source. And you want to think about the other kind of unique things. Is it a pulmonary embolism or a fat embolism? And again, prevention with all those things that I've mentioned is very important. Labs and imaging, like we've talked about, prompt administration of antibiotics. So at our institution, we do ampicillin and azithromycin for kids that have had their spleen out. They have other, things going on. You can also use levofloxacin as monotherapy. All of these patients have to be admitted. Does not matter if they look like a peach and they're not on oxygen, they can deteriorate very rapidly, and we've seen that happen. So even if they're just admitted for one day, they still need to be admitted. They'll get antibiotics, respiratory hygiene like we talked about. You can also add a little bit of 3% normal saline or CPT if they have a lot of mucus buildup in there, non-invasive ventilation, so BiPAP or high flow nasal cannula. You do want to consider a blood transfusion. You do not have to do it. It's not something that's required for every patient, but if they're severely anemic, they're hypoxic, you can't get them off oxygen, or they're kind of headed towards where they're not looking so great, think about blood transfusion. If they're in the ICU, you want to consider exchange transfusion instead of simple. ICU admission does not mean they have to have an exchange transfusion. They may be in the ICU just because you need to initiate BiPAP if you can't do that on the floor at your institution. But if it's looking like things are very much deteriorating, it's to the point where they may need invasive ventilation, you 100% need to talk to your blood bank about doing an exchange transfusion. And you want to make sure they're with good pain control, right? You don't want them splinting where they're becoming hypoventilated. At the same time, you don't want them over-sedated as well. Again, we talked about IV fluids. Steroids are another big part. So, kids with asthma may need steroids. If there is a true indication for steroids, do not withhold it. Do what you need to do, but you also cannot just stop at a 5-day course of steroids, these kids do actually need a taper, a slow taper. And that is because if you stop steroids rapidly, it can cause a rebound pain crisis. Does not always happen, but it can, and those pain crises are often actually very hard to treat. And then I'll mention briefly, you can see, rebound thrombocytosis. So as they're recovering, and that platelet count may reach 1 million. It's often that we'll see 1 million, 1.2 million. I'll consider aspirin if they're getting close to 1.3 to 1.5 million, but that number will decrease. So do not be very alarmed if you see a platelet count of 1 million just after acute chest. All right, we're almost there, I promise. Acute splenic sequestration crisis. All right, so the lifetime prevalence of this is 7 to 30%. It is exactly what it sounds like. You're going to have blood trapped in your spleen. And so that's hemoglobin and or platelets. So the spleen will become very enlarged. This 100% again is a medical emergency because that spleen can increase in size over minutes, where it leads to severe anemia and hemodynamic instability. Okay. And so these kids, when they're presenting to the emergency room, if mom or dad say, hey, their spleen is normally 1 centimeter down, or they don't usually have splenomegaly, but now it's 5 centimeter down, that is ASAP. You're getting blood work, a CBC, and you're going to get a type-in screen. You're going to feel their spleen. This is not a child, if they're at an outside hospital and say you want to transfer to CHOA, this is not one you're sending by private vehicle or by ambulance. This is one we're going to airlift them over most of the time because sadly we have had children die en route from a local hospital because it just pools and pools and pools, and it is the worst thing. Okay, so these kids get admitted and they get blood transfusion. However, this blood transfusion is slow because that blood that's pooled in the spleen has to go somewhere, right? It doesn't just disappear. So you're going to have what we call auto transfusion. So when you're giving blood, you're giving very small aliquots. Usually we do 5 cc's per kilo, and slowly, not standard rate, but over 4 hours, because you're helping that spleen auto transfuse. So if I were to give a child just a full 15 per kilo and their spleen also auto transfuses, well, now I've made their hemoglobin 11, 12, and I've increased their blood volume. I've led to hyperviscosity. And the most severe outcome that you can see from that is a stroke, which is not what we want to do. So the most important thing to remember from this slide, slow and small aliquot transfusions. Now, some kids can have chronic splenomegaly, whether they've had multiple splenic sequestrations or not, which is again why it's so important. I will teach parents at their very first visit how to feel for the spleen. You want to teach them because they need to know, okay, does my child have chronic splenomegaly? Is it, I have one where his spleen is normally 2 to 3 centimeters blue. When it gets to 5 or 6, mom knows to bring him in because he's in a crisis. And you want to get the babies used to feeling because it makes it a little bit easier for us. So just teach them at every single visit how to palpate the spleen. So some kids will have chronic splenomegaly, and the decision to remove the spleen or not is just on an individualized basis. Those that have recurrent splenic sequestration crises, you can do chronic transfusion therapy. We do that. The data is variable as to how well it works. Typically, it is a bridge until we can take their spleen out. So if they're too young, they've not had all their vaccinations, then we'll kind of bridge them until we can take their spleen out, and then they're on lifelong penicillin prophylaxis. Now, I just want to mention, so this slide on the right is kind of a representation of an aplastic crisis, which is different than a splenic sequestration. Aplastic crisis is typically caused by viruses or bacteria, most commonly, as we know, parvovirus B19. How I explain it to parents, it hits that marrow, it stuns that marrow, so it's not making any cells. So where in splenic sequestration, you're going to have reticulocytosis, and in aplastic crisis, you're going to have reticulocytopenia. So you are going to have no retics at all. So these kids do need blood transfusion. You don't always have to do slow, small. It just depends on where their hemoglobin is, but know that it can take time for their marrow to kind of kick back in and make all those cells again. Lastly, stroke. So this is a major cause of morbidity and early mortality. The risk of overt stroke, so symptomatic stroke in those with SS and S beta thalassemia 0 is about 10%. And then you can have TIA, so transient ischemic attacks and silent cerebral infarcts. And there is actually what's SCIs, there's a 14-fold increased risk of an overt stroke. So this is where primary prevention comes in with TCD, so transcranial Doppler ultrasound. We are going to image the large intracranial vessels to look for increased velocities because of stenosis. So these vessels become stenosed, which is going to increase the velocity. So that is what we're looking for. We only do this in those with SS and S beta thalassemia 0. The risk of stroke in SC and S beta thalassemia plus is much less. So we had 2 big trials. The STOP trial that showed that if you have increased risk of stroke based on TCD, you're going to start chronic transfusions. That's primary prevention, so we're preventing a stroke. The TWITCH trial showed that after a few years of chronic transfusion, if their TCD returns to normal or stable and they have no vasculopathy, you can switch them over to hydroxyurea, and it does not increase their risk of stroke. There was a trial called STOP2, which looked at just stopping chronic transfusions and not going to anything. That did not work. They had an increased risk of stroke again. So if a child is on chronic transfusions for primary prevention and you can stop it, you have to go to hydroxyurea. So stroke symptoms are like any other. We all learned about FAST in medical school, right? So face drooping, arm weakness, speech abnormalities, and time is of the essence. So these children will have symptoms of stroke like anyone else would. And as you all know, it is a medical emergency. The gold standard treatment is exchange transfusion. We're going to take out their sickle red blood cells and give them normal red blood cells. If for whatever reason there's going to be a delay or their hemoglobin is less than 8.5, go ahead and just do simple transfusion while we work on getting the exchange. Anyone who's had a stroke will be on chronic transfusions lifelong. There's no switching to hydroxyurea. They will just be on chronic transfusions, and that's to suppress their sickle hemoglobin. They're going to be followed by neurology. We have our neuropsychologists, and sometimes they'll need neurosurgical interventions. They have vasculopathy like moya that could be acted up on. And the risk of second stroke is 60 to 80%. So this is why we tell families it is so important. I know it's a lot for our families, especially that come from a rural area, but these monthly visits for exchange are very important. And just lastly, I alluded to this earlier. So the CDC has excellent handouts on sickle cell trait. It goes a little bit over the genetic counseling, what it is, why it's so important. So I think the most important thing that any provider can do is if you know the parent or the child has sickle cell trait, talk to them about it. Tell them you need to know what your partner it has if they choose to have children, because there is a risk of sickle cell disease. Again, we get a lot of families that mom didn't know she had trait till pregnancy. Dad is not sure, or neither of them were sure. Now their first or second, etc. child has sickle cell disease. And it's a big shock for them, as anyone can understand. So I think a little bit of education right from the get-go is so important. So what are the take-home points? The biggest thing I want you all to understand from this is just the hemoglobinopathy screening on the newborn screen. A lot of times we'll get families that come to us and say, oh, my pediatrician told me this isn't important, or hemoglobin SC is not a type of sickle cell disease, or it can wait till they're a year of age. This is why it's just important to understand what the hemoglobinopathy screening is telling you. Vaccination and penicillin prophylaxis, and then just understanding some of those acute, common clinical manifestations. Even if you're not treating it, as long as you know what to look out for, and you can give us a phone call and, we'll help with that. Genetic counseling, as we've talked about, and then just the role of our primary care providers, right? You guys are the front line. Yes, we are involved, but at the end of the day, primary care providers are so important because they do go to you, right? Your vaccinations, your wellness checks, just your normal sports physicals, anything like that. They're going to the primary care providers because you all have this lifelong relationship. We do too, but sometimes we're harder to reach, right? Especially if they're a few hours away. So this is why I just, the role of the primary care provider is so important, and reach out to your colleagues. We are here. You have my email. I can give you my cell phone. All of us are available. I'd rather you call us 10 times about the same thing than not call us and be uncertain. That is what we're here for, right? At the end of the day, it's all about the patient. So that's the most important thing that I think I want you to take away from this. And then there are community organizations, this is the Sickle Cell Foundation of Georgia and a lot of other local communities. We have one where a mom of patients with sickle cell has started her own organization. So there are a lot of resources out there. So I think the most important thing is we're all here for the patient. We just want them to do well. Okay, here are my references, but I hope, I've taught you a little bit about sickle cell disease and why it's so important, and hopefully you can tell how passionate we are. I love my patients and I love what I do. It is hard work, but these kids really make or break your heart. So thank you all so much. I didn't know if you wanted to do time for questions, if anyone has questions. Yes, go ahead.
Dr. Desai, thank you so much. Really appreciate it. What are your thoughts? What's the current recommendations regarding young men with or females with sickle cell trait and their ability to participate in college sports? Because some colleges are still requiring that we send them their sickle cell data, whether or not they have sickle cell.
Yeah, I have to look because I know the organizations out there have specific recommendations on sickle cell trait. So I do have to look. I mean, when kids come to me and they're in high school or they're going to play sports, I tell them it's fine as long as they're staying hydrated. That's the most common thing. These kids, they don't have the typical pain crises, but they have more pain. They can have more pain or something like rhabdomyolysis if they're not hydrating enough. So big thing is making sure they're staying comfortable, they're taking rest breaks and hydrating. But I will actually have to look at the recommendations. I know there are some on sickle cell trait out there.
Because the colleges are still requiring them to bring that paper in.
Yeah, I haven't personally had to deal with it recently, so I don't know it off the top of my head, but I will take a look at it. Yeah.
I noticed on your slide about fever, but 101s are higher. So what do you recommend? A lot of times when people come in where maybe the illness just started and they're right there at like 100.4, 100.5. I mean, I've usually still been doing like the cultures and antibiotics. Is that okay, or do you?
Yeah, some of my colleagues will say, they may say we should really wait. I say it's okay. If they've come from far away or you think, they may not come back, go ahead and grab the cultures, give them the antibiotic, and send them home with antibiotic. I have no qualms with that if you think they're going to get up to 101 anyways, especially if you send them home and they're back 2 hours. I just hate that for the families. So I think most of us are fine if that's what's best.
And then we also get the opposite too. Sometimes where they give us pushback because they're like, it's not even that high fever. They're
Like the patients.
The family, I'm seeking them.
Yeah. We have had that happen. I just counsel them as best as I can. And unfortunately, these days, we just document what we've told them and if they refuse.
Can you give me a good way to discuss Bart's hemoglobin with families? I see that more regularly than I see these others. So just to have a conversation with a parent.
So it also depends on how much BARTS is seen on the newborn screen. So for Georgia, it just says like FA BARTS, right? So normal fetal adult hemoglobin, and it'll say plus BARTS. Occasionally it'll say BARTS greater than 25%, but if it's just saying like the most common you'll see is FA plus BARTS. BARTS hemoglobin is indicative of alpha thalassemia. So typically that's alpha thalassemia trait, in which you'll see some microcytosis, so smaller red blood cells. Their MCV will be a little bit low. They may or may not have anemia. If they do, it's mild, and then their red blood cell number will be elevated. So I counsel families that they may have a very mild anemia. It can mimic iron deficiency anemia. So this is where I'll tell them that don't let your pediatrician just prescribe iron. These kids need iron studies before, but otherwise it does not affect them, but it is important for genetic counseling. So again, if and when you choose to have children, know what your partner has.
What kind of lactate level would you recommend to treat them with iron?
I usually just go by whatever the normal is. So usually normal's teens and higher. It depends on the age of the child as well and what they're doing. If they're drinking a lot of milk and their ferritin's borderline where you think it's going to drop, I just go ahead and start them on iron.
You would treat them for 3 months?
I personally do 6 months total. So I do 3 months to build up the stores that they don't have at all. And then another 3 months to increase those maintenance stores. So typically I tend to do around 6 months plus or minus, but that's usually my general. Hopefully that answers your question about BARTS though.
I had a question about vaccines, the mid-year and the Prevnar 20. I know the sickle cell patients kind of get the mid-year earlier. Non-sickle cell we started at 11. I wanted to know the start age for the mid-year. The PCV 20, I know is replacing the Pneumovax 23, and we do that per the CDC schedule. But sickle cell patients, do they get an extra dose, or do they follow the same schedule with the PCV 20 that non-sickle cell?
That's a perfect question. So yes, Menveo typically is 11 to 12 2-dose series. So it's about 50-50. Some of our pediatricians will notice that on CDC's website, it'll say you can actually start it at infancy. So at 2 months of age, you can start Menveo. So some of our kids, they'll start that series then, or you can start it at 2 years of age. So if I have a kiddo and they didn't get it during infancy, it's a 2-dose series starting at 2 years of age. So either in infancy or around 2 years of age. And those recommendations are on CDC. It's a bit hard to find, but they're there. And then PCV20. So it's now just following the normal CDC guidelines. It was with PPSV 23 that they'd get that extra dose, but now that we have 20, you just do the regular. I actually bring up an important point. So it used to be also that the data showed that they needed to be on penicillin prophylaxis till 5 years of age because that's when increased risk of infections were. But now a lot of families ask, well, we're done with our PCV 20 by much younger than that. Why can't we stop penicillin? You still do not stop it. We still keep it till 5 years of age because that risk is high. So 20 you do based on CDC. Menveo can be infancy or 2 years of age. But they do get boosters too.
What dose do you use for prophylaxis?
So 0 to 2.99 is 125 milligrams BID. 3 and up is 250 milligrams BID. That's for penicillin. We do use amoxicillin as well, especially when we had shortages of penicillin or a child just doesn't tolerate the taste of penicillin. Everyone does it a little bit differently. Technically, amoxicillin dosing is 10 milligrams per dose BID. And then at some point, you'll get to that 250 milligram BID and you just stay there. Some providers will do the same penicillin dosing for amoxicillin dosing for ease. So we have seen that, but technically amoxicillin is 10 per kilo per dose BID. Excellent. Any other questions? Again, I'll be available here throughout lunch if you all think of something. Okay, well, thank you all so very much.